So first we're going to hear from John Graves, who's an assistant professor in the School of Medicine. He holds appointments in the health policy and in the Department of Medicine. And Professor Graves works on the development, implementation, and evaluation of healthcare reforms at the state and federal level, and is a very well-known scholar who's both present in the media and legal realms, who works on really the implementation of the Affordable Care Act in the U.S. South. Then we're honored to welcome Mayor Bill Purcell, who was the 5th mayor of Nashville. He was elected in 1999 and then re-elected to a second term in 2003. He was also worked at the Harvard University's Institute of Politics and the School of Government, and he's also been working in numerous health-related realms since that time. And he's since, I think, returned to private practice also in Nashville for law. Then we're welcoming Consuelo Wilkins, who's the executive director of the Meharry-Vanderbilt Alliance, a partnership between Vanderbilt and Meharry. She has numerous appointments across the school and is co-director of the Vanderbilt Community Engaged Research Corps. And she brings together researchers and community members to improve community health and healthcare through really community-engaged research. Then we're going to hear from Evelyn Patterson, who's an assistant professor of sociology and also affiliated with us at MHS. And she's also a health policy associate at Meharry, and a very well-known scholar on incarceration, and particularly incarceration in men of color in the U.S. South. Then we're going to hear from Beth Roth, who's the executive director and policy director of the Safe Tennessee Project, which is a very cross-cutting, politically engaged group that looks at gun violence research and gun violence activism in the U.S. South. And then we'll finish with the amazing Sarah Rudasill, who is a junior at Wake Forest University. Now, she was going to initially talk about the student perspective, but it turns out she's going to put us all to shame with her incredible research about comparing the US and Europe in terms of Medicaid expansion, and really a leading, I think, student voice about issues of health and looking at the health expansion in the South. So with that, why don't I welcome John Graves.
Okay. All right. Well, it's great to be here, and it's great to be the first official speaker for the conference. What I thought I'd do is spend my 10 minutes or so first providing just a general overview of what's going on in the South as it relates to federal health reform that we saw passed in 2010. And then if I have enough time at the end, I'll highlight some work we're doing here at Vanderbilt, which will effectively be one of the largest evaluations of health reform in the South or even in the United States more generally, which just kicked off last year. So just to set the stage for my remarks, leading up to 2010 when the Affordable Care Act passed, really the rallying cry behind the proponents for reform in Washington, D.C. and elsewhere was this observation that the United States, kind of uniquely among industrialized countries, had a very large and growing population of people without health insurance coverage. So we went from, in 1988, about 31 million people uninsured to nearly 50 million on the eve of the first wave of major coverage expansions under the Affordable Care Act. And the fact that we have so many uninsured and large growing numbers of uninsured is really symptomatic of broader issues in the healthcare system. That is healthcare spending that's outpaced the growth of incomes in the United States, and a very fragmented insurance system that was increasingly characterized by very frequent disruptions in coverage, which has been a focus of my own research. So this isn't my formulation, but I think it's a really helpful way of thinking about at least the insurance provisions of the Affordable Care Act as this kind of three-legged stool. So I usually do this in an hour, but I'm gonna do it in 2 minutes. So on the one hand, we had a system, if you didn't get coverage through your employer or through Medicaid or some other federal program, you were basically left to buy coverage on your own in what's called the individual or non-group market. And prior to 2010, that market was characterized by all these nasty things like being denied because of pre-existing conditions, or basically getting priced out because of pre-existing conditions or other reasons why an insurer might think you were unhealthy and unfit to be insured or have health insurance. And so one of the legs of the stool, which I'm not going to focus on, was basically a lot of regulatory reform to that non-group market. Basically, insurers, starting with the Affordable Care Act, can no longer underwrite. They can't deny people based on pre-existing conditions. But if you do this kind of in isolation, what you're left with is a system where basically the only people that are going to sign up for insurance are the people that think they're going to need medical care. And so you need to kind of ensure a stable underlying risk pool where at any given time you have healthy people paying premiums to offset the cost of sick people. And that was really the reason why we have this second leg of the stool, which is the individual mandate, which basically says that if you can afford insurance in the United States, then you should have insurance, whether through a public program like Medicaid or through your employer or through purchasing it on your own, like through healthcare.gov or the state websites. And then finally, if you're going to compel people to carry insurance throughout the year, you can't reasonably expect, in a world in which a family insurance policy costs about $17,000, a family at the poverty line might be making, $20,000. Their premiums alone would consume almost all of their income. And so the Affordable Care Act set up this third leg of the stool, which is the insurance subsidies and Medicaid expansion. And I want to focus on that because this has really been the crux of why states, in particular states in the South, have been debating what their role in the Affordable Care Act should be. And that's because the way the Affordable Care Act was set up, if you look at that leg of the stool as a kind of like income spectrum, starting from 0 at the bottom as a percentage of the federal poverty level, all the way up through the highest income people. What they did is between 100 and 400% of poverty, they basically set up a new tax credit so that it would offset your premiums if you purchased coverage in that reformed individual non-group market that I just mentioned. But the subsidies actually started at 100% poverty. They didn't start at 0% poverty. So for the lowest income people in the United States, what the Affordable Care Act set up was an expansion of the public Medicaid program, which is administered by the states. It's jointly run with the federal government. But as a result of all the legal challenges to the Affordable Care Act, in 2012, one of the results of that was that the Supreme Court said that Medicaid expansion, where the federal government was telling these state Medicaid programs to expand to populations they weren't already serving, the Supreme Court decided that was optional for states, so they didn't have to expand Medicaid. And what this created, because of the structure of the Affordable Care Act, is what's known as the coverage gap. So people between 0 and 100% of poverty, if their state has decided not to expand Medicaid, are really ineligible for affordable health care under the Affordable Care Act. And what we saw is that decision refracted through basically the politics of the current moment. And I've highlighted the South. I haven't included Texas, sorry. Going to definitions of the South, but what you can see is the unique among almost all regions of the country, the South. The yellow states here are the states that have not expanded Medicaid as of March 1st of this year. The blue and green states are states that have. And you can see predominantly southern states have opted not to expand Medicaid. And so the debates that we're having on the US South when it comes to healthcare policy are really heavily focused right now on this decision whether or not to expand Medicaid. And as we get farther and farther away from the enactment of Obamacare as Obama leaves office, I think we're going to see a really significant change in the tenor of that debate. And I want to highlight that in my remarks here over the next couple of minutes. So ironically, despite the fact that the South is unique among regions in terms of its reflexive, almost opposition to the Affordable Care Act. 6 southern states rank among the 10 states with the highest uninsured rates in the United States. And if you look at the population potentially eligible for that Medicaid expansion, about 80% of those people reside in the South. And so we have this kind of situation where the success or failure of the ACA to achieve one of its main objectives, which is to achieve near universal coverage in the United States, is really going to be determined in the South based on these decisions whether or not to expand these state Medicaid programs or how they expand. And so what we're seeing throughout the South is a very increasingly more nuanced debate about whether or not, despite the political leanings of these states, they should go ahead. There's a lot of federal money at stake. The federal government is subsidizing the vast majority of these, the cost of these expansions. And what we're seeing is a lot of southern states start to loosen up a little bit in terms of how they approach, they're beyond the kind of reflexive opposition to expansion, and they're starting to engage a little bit more about, well, if we do it, we're not going to do it like everybody else did. We're going to have our own kind of flavor of how we reform our Medicaid program. And so what I think we're going to see over the next few years, in particular starting next year, are potential expansions of Medicaid, but with a very distinct kind of southern flavor, if you will, where the states will basically apply for expansion, or whatever they call it, through the form of a waiver with the federal government. And so the idea of this is to tweak the design of what's traditional Medicaid by waiving certain requirements. And so these could be things like, well, I'll get to it in a second, but basically the idea is to tie this effort of Medicaid reform to expansion. And it allows, I think, a nice way to differentiate away from Obamacare by saying you're doing something on your own. And it also provides a plausible path forward for kind of achieving this vision of near universal coverage. So the key point is that the South, I think, is going to be a key incubator for these state approaches. So what we're going to see, particularly in the southern states, and also elsewhere for that matter, are kind of three flavors of what Medicaid might look like. So one is the provision of private insurance rather than traditional public programs like Medicaid. And so we are actually already seeing this in our neighboring state in Arkansas. This is also known as the private option. So the basic idea is to use the dollars that would have gone to Medicaid to purchase private coverage for these individuals that would otherwise be eligible for the expansion. In other states, you're also going to see an attempt to reform the Medicaid program to be kind of more, quote, consumer-driven. The idea is that we would couple some modest cost-sharing requirements like co-payments for emergency services or doctor visits, for example, with like a health savings account-like program. And so we might see not necessarily the use of private insurance like we are in Arkansas, but a reform of traditional Medicaid to incorporate some of these kind of more consumer-driven ideas of co-payments and cost-sharing. And then lastly, another flavor you're going to see are these kind of programs that try to incentivize healthy behaviors. And so what that could take the form of monetary or a material motivation for promoting healthy personal behaviors like enrolling in a smoking cessation program or going to get an annual checkup, etc. And the receipt of Medicaid might be contingent in some ways, or it might be cheaper to you at the point of service, like they might waive your copay if you engage in some of these healthy behaviors. And so these are the kind of flavors that we're going to see kind of crop up throughout southern states as they engage or start to engage with the federal government in terms of moving beyond the kind of reflexive opposition to the expansion that we've seen in the last 5 years and towards a kind of state-focused approach with a southern twist, I guess. And this is where the evidence from researchers like myself and my colleagues in the Department of Health Policy and MHS is really starting to inform this debate within Tennessee and throughout the region and nationally. And so there's really key evidence early evidence, albeit, starting to come out, finding really no significant differences between expansion in Arkansas versus through this kind of private option of giving people private coverage versus a more traditional Medicaid expansion, which is what we saw in Kentucky. And so as we think about and debate whether or not we should adopt some of these flavors into our Medicaid programs, it's really important to kind of understand this research. In particular, I think, as someone who kind of initially came into this thinking that co-payments might be something we could consider, the research is really starting to show that co-payments are such a blunt instrument that they really kind of, they work in some ways, but they also provide a significant headwind to achieving some of the objectives that they're set out to achieve. And so I'm going to leave the rest of my remarks to later in the panel, but and pass it on to Bill.
So I was sitting there looking at this panel as you are and thinking about that test that was my favorite. Probably explained how I got into law school. That test about what doesn't belong in this group. And I think it's me. I'm the lawyer, politician, who isn't going to have a PowerPoint, and in fact is so old school that I actually want to begin with, this is a newspaper. Here it is. It's hard to tell, those of you that are my age, because it begins actually, it looks like the sports section at the top, and then at the bottom there's a rather nice human interest story about adoption. There's a small political conversation in the middle, but I thought I should look at this newspaper because actually my entire presentation was reported online. Not knowing that I was going to give it, the Tennessean actually went down and covered the legislature yesterday and printed it today, and I wondered, because it's important, at least it used to be, where does the newspaper think this particular issue belongs in the news of the world as presented to the people? And on this particular day in Nashville, Tennessee, actually on page 3, there are 3 political stories. The first is about lead in water in 2 communities in Tennessee. The second is about politics, sinking insured Tennessee bills in the House. And in fact, the story goes on to report exactly what happened, and I encourage you to look it up. It presents rather prominently on the Tennessean's website 2 proposals, one for a referendum across the state to see what the people of Tennessee actually wanted to do on the subject of Insure Tennessee and Medicaid expansion. The other was sent to a summer study committee, which effectively ended its importance as well. And the story begins, presidential politics and disappointment over legislative leadership took down 2 proposals regarding Insure Tennessee in a House subcommittee. And goes on to talk about what the political leadership in the state is saying on this subject. Among the most important findings was the member and a leader who said, we really need to see who's going to be the next president. When we know who the next president will be, then we will know what we should do. And talks actually in some detail about the fact that there are some candidates for president who aren't as confident about the way in which this will all play out as the research has to this point. Without quoting at length or specifically what politicians in Tennessee have said, let me begin with some unquestioned authority from a distant time. Dr. Albert Schweitzer once advised, and I quote, happiness is nothing more than good health and a poor memory. On that particular formulation, at least as to happiness, you'd have to suggest that we're not doing so well in the South. On the annual health rankings, we have, for most of my lifetime, found that it is the southern states that bring up the last, in this case, 8 places. Indiana jumps in there between South Carolina and Georgia. New Mexico, Nevada, Ohio jump in before you get to Missouri. Michigan leaps in before you get to number 34. Texas, Florida, 33. Delaware was a southern state. It wasn't on the maps as a southern state. South of the Mason-Dixon line. Delaware, 32. North Carolina, 31. A southern state that gets into the top half of states, you have to go to Virginia at 21. And so it has been, and it feeds, I think, this notion of a monolithic as well as an historically consistent region of the country. And a little bit of what I'd like to talk about is what's right and what's wrong about that political analysis and what effect that may have on our own judgments about what's about to happen. I think Jonathan did a nice job of talking about how we do need to think about the history of all of this as telling us not just how we got here, but also why. It's actually during the time of Harry Truman, who was pursuing national health care, you may recall, that suddenly the first major investment in hospitals begins, and the Hill-Burton Act is passed, and that Hill-Burton Act begins to actually channel federal funds in a very significant way and in a much above average way into southern hospitals. As you move a little bit forward in this discussion, during the 50s, there's lots of talk further about Medicare and opportunities for extending health care, especially to the is led by Southerners that actually does, in 1964, pass Medicare as a significant, I would argue, the largest expansion prior to Obamacare of health care in this country. It's now the early 1990s. And they begin to pursue, again, First, a bolder expansion, much like what our current president attempted, but then ultimately the other kinds of incremental expansion of Medicaid, especially for children, that leads into where we are now. But I want to drill down for a moment here into Tennessee, because it's in 1994, actually, that the governor of this state stood up. This is April 8th, 1993. His name was Ned McWhirter, and he began an address to the legislature. And I was sitting there that day when he said, "Every man and woman in this body offered themselves for public service, knowing a day would come when you'd be tested by fire. Today is that day. I stand before you to recommend that the state of Tennessee withdraw from the Medicaid system and establish a radical new program for the delivery of health care. At stake is nothing less than the financial stability of state government and the access to health care for 1.5 million Tennesseans." And that began the implementation of a program that was ultimately called by the name TennCare. And the result of that was that from basically 1994 till almost the end of the decade, Tennessee was number one in insured population numbers in America. We were above Hawaii in the actual provision of health insurance and service to the people of the state. At that moment in time, which was not a single moment, but actually a series of years, Tennessee moved to the front, not just of southern states, but of all American states in providing for insurance for its population. As I think the Tennessean makes clear in its story, and I think as well, both what we've heard and what we will hear also reinforces that's not where Tennessee politically is today, and arguably, of course, that's not where the majority, in fact, more than arguably, certainly that's where the majority of the southern states are. It is absolutely the case that Kentucky adopted the expansion, Louisiana adopted the expansion, as was made clear, West Virginia, which I would count among our states, did as well. Kentucky, the new governor is ambivalent about the expansion. In Louisiana, indeed, the new governor is very supportive of the expansion. There are complexities in each of these places, but the South overall continues to resist, and as I think the politicians yesterday in the majority in Tennessee said, awaits political activity that will be occurring elsewhere. What I would say to you is that for the future, probably the best place to look is not the past, although it's instructive. It is to look specifically at where the people are in this state and in the other states as well. And for that purpose, you have the Vanderbilt University poll, last conducted in November. It's done by John Geer and Josh Clinton. They're the co-directors. You know John Geer, of course, as our associate provost here. And what the last poll shows is very straightforward. Now 24% of the people of Tennessee, irrespective of party, suggest that health care is a priority for the state. That's up from 12% when they began the poll in May of 2012. When you look at how the people of Tennessee feel about politics overall, irrespective of party, 66% of all respondents, 63 of Democrats, 68 of Republicans, 67 of independents, 58% of Tea Party members, they agree absolutely about one thing. They're frustrated with the political system in this state, in this country. But then also they agree about something else. Basically, they support Insure Tennessee. 64% of Democrats, 64% of all respondents support. Only 16% strongly oppose or oppose the expansion of Insure Tennessee, of Medicaid in the state of Tennessee. And when you get to partisanship, even a majority of Republicans support that effort. And they, across the board, support funding for women's health organizations, whether this is an organization or one named specifically, otherwise politically sensitive in other places. What am I telling you? I'm telling you that the people of Tennessee, when asked these questions about what should happen in terms of health care, believe in a striking number that it should indeed expand, that the governor, a Republican, should in fact have his way on these policies. And when you look down to the local level, whether you're talking about the political leadership or the actual business leadership here, you find the same kind of thing. So for the future of politics, if indeed politics follows the people, then you have some sense of where we will go. If you look at the past, you have some sense of where we've been and where we could be again. But as to what will happen, I will await the rest of the panel.
I didn't ask Jonathan's permission to put my Twitter handles up there, but just in case, I thought I would share those. I'm delighted to have the opportunity to share some thoughts about research in the South, and I will join Mayor Purcell with no slides. As a physician and researcher, I usually have slides, and last week I was at a Robert Wood Johnson Foundation meeting where I was on a panel. I was the only one with slides, so I said, I'm not going to have slides today. And I can't tell, I don't know if I feel bad that I didn't join John with slides, or I feel good that I joined the mayor without slides, so you can decide later. So I was asked to think about or talk about, bring some thoughts about research in the South, and I want to make a few points. So one is, I want to point out what's good, but also where we need to go. I want to describe a few of the challenges I think we've faced in research, especially research that leads to improvements in health outcomes, and what I think are perhaps some solutions that we should be working towards. Now, yes, I know I'm supposed to do that all in 10 minutes, and I think I only have 8.5 left. So what's good about research in the South? And I should clarify, when I say research, I'm specifically talking about biomedical research. That's the lens that I wear. And so research that's from discovery to impacting public and population health. So if you look at NIH, National Institutes of Health, funding for research, and the amount that goes to different research institutions, most of those institutions are not in the South. That certainly doesn't mean that we don't have great researchers or great research being conducted in the South, but much of that research is actually done outside of the South. If you look at those institutions that have the most NIH funding in the South, at the southern border of those who are in the top 20, Vanderbilt is one. Depending on where that latitude line drops, going east, you get to UNC and Duke. But in the top 20, there are very few institutions in the South that are bringing in all the research dollars from NIH. Now, again, what does that mean? So when we're doing research, we're typically doing research with populations, with communities nearby. We're recruiting if we're doing clinical and translational research in those nearby communities. And so a lot of the discovery that's happened, a lot of how healthcare has been shaped from the research standpoint has not been done in communities in the South. Another challenge we have with improving the health and leaning on research is that among those institutions that receive NIH funding and other funding, historically Black colleges and universities tend to be at the bottom of that list. Historically Black colleges and universities, there are over 100 in the country. Many of them, though, formed in former slave states. They formed out of the necessity of individuals who are slaves or descendants of slaves needing to be educated and not being able to get into some of the more affluent colleges or being able to afford them, travel the distances to them. And so we have a preponderance of historically Black colleges and universities in the South, and we have quite a few here in Nashville and in Tennessee. So certainly it's already been acknowledged, Meharry Medical College, one of the 4 academic health centers that is historically Black, is here in Nashville. Those tend to be under-resourced. The infrastructure is not as sophisticated. Even though the scientists, the educators, the students are brilliant, it's really a challenge to do research of the same caliber when the resources are not there. Thinking again about what the population of the South looks like and the amount of poverty that's there. So back to Jonathan's maps of the South, that really you can overlay the poor outcomes, the obesity, the heart disease, everything that's bad with poverty. And so sometimes we overlap too much race, ethnicity with poverty, but certainly in the South it's hard to disentangle them. But let's think for a minute if we were going to study poverty, if we were going to study the impact of slavery. So from a scientific rigor standpoint, Thinking about how I and my biomedical research colleagues would do this, we would probably start with mice. So let's think about some mice. We're going to have mice here on my left, your right, and some on my right, your left. These are going to have normal living conditions, as normal as your living conditions can be if you're a mouse, in a lab. Think about that. Free access to whatever healthy food, grains we're providing you. The wheel, whenever you want to get on it, is there. Time to, interact with the other mice, social times, that thing. And then on the other side, we have mice that are enslaved or in poverty. So mice who have been removed from their family members. They're isolated. They're not given the good, healthy food. They're given the scraps, the bad things. They're not allowed to get on the wheel, or if they are, it's not really a nice wheel. It's kind of the clunky one with maybe some steps missing on the ladder. Who knows what's going on in the wheel? If we design that study, and some versions of this have been done, so we do this all the time to poor mice. We give the one group some healthy grains, and the other some fatty ones, and one gets vitamins and the other one doesn't, and another one gets the wheel, and so on and so forth. So if we were thinking about this, and if I were proposing this to my colleagues in science, no one would be surprised that the mice on this side have worse health, that they're disadvantaged in many ways. But we don't have that opportunity to study the impact of slavery and poverty in that way, because mice don't live that long, and we can control them. And so we're left to sort of think about how do we have research, how do we design healthcare that will really impact this population that has suffered the impacts and the effects of being descendants of slaves and being in structures that are not well resourced. So I think that's among the many challenges that we have as we think about how do we bring more research into the South, and also have that research improve the outcomes of Southerners. So I'll leave you with what I think some of the most important things we can do for that. So one, I think we have to change our approach to research and make sure that it is really more transdisciplinary. And what does that mean? So we have to get out of our disciplinary silos where only the basic scientists and discovery folks are working with each other, and the clinical researchers are working with each other, and the social and behavioral scientists are working with each other. But we have to create new opportunities for us all to work together, and certainly to bring in the clinicians and the population in the community. And obviously, this is the world that I live in, so I'm talking about my own Kool-Aid that I drink. It's really key if we're going to move research into improving health outcomes that we have to talk to people who really know more about poverty than the average biomedical scientist. And we have to bring in those who are impacted by poor outcomes to make sure that we're aligning the priorities. I also think that we have to push the policy to make sure that we're actually getting more funding to historically Black colleges and universities to do research, and other researchers who are studying those who are underserved and disadvantaged. Otherwise, it's going to be really challenging for us to think differently about the approaches that we develop and the research that we do if we're going to really improve the health outcomes of the South. Thank you.
Justin, do you know? Oh, this is the gun one. Is it on? That one? Why don't we go? Why don't we back go and load your slides? Beth, do you mind?
Sure.
Can we just get the AV help real quick?
Good afternoon. It's an honor to be here today on such a distinguished panel, and thank you to Dr. Metzl for including me. My name is Beth Roth, and I'm the co-founder, policy director, and executive director for the Safe Tennessee Project. We're a nonprofit made up of academics, physicians, and citizens focused on better understanding gun violence and how to reduce it here in Tennessee. Our organization fully supports the Second Amendment and citizens' rights to have guns. We do believe, however, that there are some public health and common sense policy issues we should consider that would both respect the Second Amendment and keep more Americans safe from gun violence. Trying to get at the root of any issue, especially a public health issue, starts with understanding the hows and whys of the problem. Unfortunately, when it comes to gun violence, finding good data is difficult. 20 years ago, the NRA passed a bill that banned federal funding of gun violence research. The bill's sponsor was a congressman named Jay Dickey, and the funding ban is known as the Dickey Amendment. Interestingly, Congressman Dickey, who is retired, has reversed his stance on the issue and now says he regrets his involvement in getting the amendment passed. In fact, just a few weeks ago, in a bit on The Daily Show, they brought together Congressman Dickey and former public health researcher Mark Rosenberg, who had fought against Dickey's amendment in 1996. The two are now working together to lift the ban. The last time there was any congressional movement on the ban was on June 24th, 2015, exactly 1 week after the Charleston shooting. A move to reverse the ban was voted down. Our country has a problem with gun violence. Every day, on average, 289 people are shot, 86 of them die, 30 are murdered, 53 kill themselves, and 2 die accidentally. The U.S. firearm homicide rate is 20 times higher than the combined rates of 22 countries that are our peers in wealth and population. A gun in the home is 22 times more likely to be used to kill or injure in a domestic homicide, suicide, or unintentional shooting than to be used in self-defense. An average of 8 children and teens under the age of 20 are killed by guns every day. American children die by guns 11 times as often as children in other high-income countries. We have a gun violence problem here in Tennessee. Tennessee is 9th in the country for homicides. We're 9th in the country for accidental shootings. We're 6th in the nation for women murdered by men. 600 Tennesseans each year use a gun to kill themselves. Around 20 Tennessee kids will use a gun to kill themselves this year. In 2014, gun-related deaths surpassed motor vehicle deaths in Tennessee. Last year, the CDC noted accidental shootings as the most distinctive cause of death in Tennessee. Gun violence costs Tennessee a whopping $6.3 billion per year. Guns and Ammo ranks Tennessee as the 23rd best state for gun owners, while the Law Center to Prevent Gun Violence gives our gun laws an F. In 2014, over 1,500 handgun permits were suspended or revoked, and over 1,600 were denied. In 2013, after Sandy Hook, Tennessee passed an NRA-written law to keep all permit holder information confidential, making it illegal to collect any data on permit holders who use firearms to threaten or commit crimes. Background checks are not required for all gun purchases in Tennessee. Last fall, the Violence Policy Center a national nonprofit organization that provides research, investigation, and analysis on gun violence, released their annual report, When Men Murder Women. The VPC has published the report annually for 18 years. Using data from the most recent available year, 2013, the study revealed that over 1,600 U.S. women were murdered, and the most common weapon used was a gun. The report ranks all 50 states. Tennessee has consistently been in the top 10. In last year's report, we were 10th. In this year's report, Tennessee is ranked 6th, tied with Oklahoma. In 2013, 55 females were murdered in Tennessee. 3 victims were under age 18, 2 were over age 65. The average age was 39. 60% of women murdered by Tennessee were white. 63% of victims were killed with a gun. 59% were killed with a handgun. The rest were killed with a rifle or shotgun. 98% of the victims were murdered by someone that they knew. Of the victims who knew their murderer, 70% were wives, common law wives, ex-wives, or girlfriends of the offender. 95% of the murders were not related to the commission of any other felony and were most often the result of an argument. Homicides, including those involving young people, are up dramatically from last year. The Nashville 2015 murder rate almost doubled the 2014 murder rate. Nashville leads peer cities in youth homicides. Last year in Nashville, 20 people aged 19 or younger died in criminal homicides. Although homicides dipped 4% last year, Memphis logged a staggering 138 criminal homicides in 2015. According to the Centers for Disease Control, unintentional shootings remain a top 10 cause of accidental death for children ages 1 through 4 and 10 through 14. Tennessee is 9th in the nation for accidental shootings based on the CDC WISCAR's data. Many of these involve children. Accidental shootings involving kids are most often associated with improperly stored firearms. Responsible gun owners also accidentally shoot themselves or others, often while cleaning their guns. In 2015, there were at least 24 unintentional shootings involving a child with access to a loaded unsecured firearm here in Tennessee. 14 children were injured, some seriously. 10 of them died. The youngest victim was 2. One 8-year-old little girl in White Pine, Tennessee was intentionally shot by her 11-year-old neighbor over a puppy. He used his father's loaded shotgun to kill her. So far this year, there have been 5 unintentional shootings involving a child with access to a loaded, unsecured firearm. 3 of the children were injured. 2 of the children died. They were 7 and 3. Tennessee is currently considering strengthening our child access prevention laws, or CAP laws, to impose criminal penalties when a child accesses a loaded gun and injures themselves or someone else. In a recent Johns Hopkins School of Public Health study, not a poll, sorry about that, Tennessee was flagged as one of 7 states with a disproportionate number of accidental shootings. All 7 of the states, West Virginia, Kentucky, South Carolina, Louisiana, Arkansas, Alabama, and Tennessee, are in the South and in states with high rates of gun ownership. The researchers noted that none of the states have laws requiring the safe storage of guns, which have been shown to prevent accidental shootings, particularly among children. So far in 2016, the number of accidental shootings involving adults is nearly triple the amount from the same time last year. 2015, January through March, there was a total of 5 accidental shootings, 5 injuries, and no deaths. So far this year, these numbers are actually not right because there have been some additions to them since I completed the PowerPoint at the end of the week last week. Unfortunately our numbers have gone up. On Monday of this week, a 19-year-old girl was accidentally and fatally shot. A friend was cleaning or handling a gun in the room next to her, and his gun fired, sending a bullet into her room and killing her. There was also another accidental shooting that occurred late last Friday when a man was cleaning his gun, and a man who'd been injured in February when the gun he was carrying discharged as he was exiting his vehicle passed away this week due to complications from his injuries. For adults, we're now at 16 total incidents, 13 injuries, and 3 deaths. Combating the gun culture. Any kind of discussion about guns, gun rights, gun violence prevention can become immediately polarizing in all parts of the country, but especially in the South where there is a strong gun culture. Many households in the South have guns in them. Well over half the population of Arkansas owns guns, and nearly half of the folks in Alabama and Louisiana also own guns. Just as a reference, as you're looking at this map, the Johns Hopkins study noted West Virginia, Kentucky, South Carolina, Louisiana, Arkansas, Alabama, and Tennessee as the states with the highest number of accidental shootings. This is a scorecard of gun laws from the Law Center to Prevent Gun Violence, a nonprofit organization of lawyers and legal experts that focus on both the federal and state firearm laws. Their rankings are based on a series of criteria, such as whether a state has background checks, whether a state has laws that prohibit domestic violence offenders from purchasing guns, or whether states have laws that weaken public safety, such as allowing guns in bars, which we have here, on college campuses, which our legislature is trying to pass this session, or allowing concealed carry without a permit, which we were able to defeat this session. The gun lobby is very powerful, both nationally and here in Tennessee, and they exert a lot of power. In 2012, the NRA spent over $141,000 to elect pro-gun legislators here, and the TFA, the Tennessee Farms Association, spent $15,000 to elect pro-gun legislators. To try and make headway as a gun violence prevention organization in the South is an uphill battle. It requires building coalitions of like-minded organizations. These are some of the organizations we work with. It also requires a strategy. Our strategy is three-pronged. We want to change hearts. The toll of gun violence is undeniable. The death of mothers, grandmothers, sisters, fathers, grandfathers, brothers and sons, daughters and friends leave grieving loved ones. And there is a financial aspect to it as well. We also want to focus on changing people's minds. When most people think of gun violence, they think of spectacle mass shootings by crazy people in gun-free zones, gang shootings and bad guy armed robbers and criminals. But the reality is that that's not correct. A mass shooting is defined as 4 or more people shot or killed in a single incident. There is a lot more that I could discuss on this topic, but we are running out of time, so I will end there. Thank you.
Then we'll let Sarah go, and then Evelyn, we've got your slides, so we'll do you last. Okay. All right, we're back on track.
All right, well, good afternoon, ladies and gentlemen. My name is Sarah Rudasill, and today we're going to be talking about female breast cancer incidence and mortality ratios in the United States and in the United Kingdom. And so I think this is really important in discussing some of the challenges facing, especially policymaking in the U.S. South. And when you walk out of here today, I would like you to remember 2 things. The first is that the United States actually achieves better overall breast cancer outcomes than the United Kingdom. And that's according to cancer mortality rates. Pretty cool. However, black women have significantly worse health outcomes relative to white women. This is true in both the United States and in the United Kingdom, but it's especially exacerbated in the United States and especially exacerbated in the US South. And so we're going to be talking about why that might be. But before we do so, looks like some of our alignment's off a little bit, but we're just going to talk about the major points of each health system that are going to be relevant to our discussion today. So the first thing that you should know is that the National Health Service actually provides universal coverage to its citizens through local administration of weighted capitation budgets. So they give each clinical commission group a set amount of money, and they use that money to pay for the health services of the local population. This is in stark contrast to the United States, which has this public-private health conglomerate. Everyone's technically supposed to have insurance, but we know that that isn't the reality. Second thing that you need to know is that in the United Kingdom, since they have these fixed budgets, They actually have an institute responsible for cost effectiveness decisions. Interestingly, this is called NICE, and what they do is they look at each treatment and drug that becomes available, and they use cost effectiveness as defined as approximately 20,000 to 30,000 pounds per quality adjusted life year earned. If they don't deem it cost effective, it is simply not offered to UK citizens. On the other hand, if we look at the US, we have no such institute for cost control. We don't really make cost effectiveness decisions. If insurance will pay for it, it will get paid for it. And as a result, we see some of the highest healthcare spending in the world in the US. The third relevant point to all of this is that the National Health Service, they actually provide services free at the point of delivery. So you walk in, you receive your medical care, you don't have to pay anything. We all know that this is not the case in the United States. You pay a premium, and then on top of that, you have co-payments and deductibles and co-insurance. So these are going to be the themes that are relevant to our discussion today. So now the question becomes, are there differences in the relative health outcomes for female breast cancer patients by race in the United States, and specifically we're looking at the US South, and then the United Kingdom. And this is all government data from the year 2012. So we're going to start with a macro perspective. What does it look like just with the basic mortality rates? Well, as you can see, sorry the formatting, something was wrong in the conversion, but we'll go with it. On the right-hand side, the right 5 are actually the US, and the left 5 are the United Kingdom. And what we find is that in the US, they have significantly lower cancer mortality rates than in the United Kingdom. Actually, the worst performing US region, which is the Midwest, outperforms the best performing region of the UK, which is Northern Ireland. So we should feel pretty good about ourselves, right? Everyone talks about how the US healthcare system is underperforming. Well, look at us, we're pretty good with cancer mortality, but it's a little bit more nuanced than that. And so we start to look at breast cancer incidence. This is the first part of the story. So this is breast cancer incidence relative to our reference group, and the reference group is women are diagnosed with breast cancer at a smaller rate than white women. In the US South, black women are almost diagnosed at the same rate, but not quite. So this is interesting to note, but what's really important then is moving on to mortality ratios. So what we learn from this is that despite being diagnosed at a lower rate, black women are actually more likely to die of breast cancer than white women. This is interesting because it's a trend that does not hold true for other minority groups. Asian women and other minority women were also diagnosed at lower rates, but yet they also have mortality rates that are lower than those of white women. Interesting. The second trend that I want to point out is that the US has significantly higher mortality ratios for black women relative to white women than the UK, and this is particularly true for the US South. So in the US South, for every 100 white women expected to die of breast cancer, we would expect 143 black women to die. In the UK, for every 100 white women who die, we would expect 127 black women to die. Both are elevated, but it's especially exacerbated in the South. Now is the range of disparities. So if you look at the United Kingdom, there are some elevations and some depressions, but everything's kind of huddled around that basic reference group. That is not the case when we look at the US South and the United States. So other minority women have really low mortality ratios, black women have really high mortality ratios. You see that disparity on the graph there. So we're not quite as equal of a society in our healthcare provision in the US. So how can we explain some of these trends that we're seeing? Lower overall mortality rates. How are we doing this on an overall perspective? I think the answer really lies in how aggressive we are with our screening. So in the United States, women between the ages of 40 and 44 are starting to be encouraged to pursue a mammogram. There's annual screening for women aged 45 to 54, and then it's biannual screening after that. It's actually not uncommon in the United States to hear of a woman who starts a mammogram at 35 if she's really high at risk. That is not the case in the United Kingdom. You actually don't get your first mammogram until the age of 50, and then it's every 3 years after that until the age of 70. This is problematic because stage 1 breast cancer is a lot easier to treat than stage 3 breast cancer, and catching these things early helps to ward off that mortality. I think this is also the reason why the UK has a higher black mortality rate relative to their white women. It's actually because, according to certain studies, black women are more likely to be diagnosed with breast cancer at an earlier age due to genetics and hormonal influences. So the UK is simply not catching it early enough, and that may be why we're seeing those higher mortality rates. Another reason why the US may be performing better overall is just because of the treatments that we have offered. So in the UK, a lot of these drugs are very, very expensive, and so a lot of cancer drugs simply are not offered. One example is Herceptin. It's a relatively new breast cancer drug. It is very, very expensive, and NICE determined that it was not cost effective, but if your insurance company will pay for it in the US, you will certainly receive it, and it provides an extra 6 months of life. That really might not seem like a lot, but if it's a woman who wants to spend another 6 months with her children or wants to, see a life milestone, those 6 months become really critical, and it's hard to put a dollar value on that. But the second trend that still exists is the US experiences greater inequality in mortality rates. So we understand why the UK why black women might have a higher mortality rate, but what's going on in the US? And the answer is that it's a multitude of different factors. So one of the things are just magnified intersectional effects. So the proportion of US black families below the poverty line is twice that of white families. And this contributes to the amount of education that you can get and your knowledge of self-care practices. There's links to your access to healthy food, and diet has a link with breast cancer, and it could explain some of the outcomes. Poverty determines your access to safe housing and your environment and what kind of carcinogens you're exposed to, which again could help explain some of that disparity. Going along with poverty is just a basic lack of financial access. So if you do not have health insurance, you are more likely to die of breast cancer than if you do have health insurance, simply because you can afford the treatments, the prescriptions, all of the medical care that goes along with facing something like breast cancer. We add these things in, like co-payments and deductibles, in order to deter unnecessary medical care, but a lot of the times it just ends up deterring necessary medical care, and that's where we see those disparities rise. The problem is that financial implications don't explain all of it. There is still inherent general mistrust of the medical system stemming back from historical roots. So if we go back to the Tuskegee syphilis experiment, where we have nearly 400 black men enrolled in the study on syphilis, and penicillin becomes available, and yet we still do not offer it to them, it is no wonder why black patients are less likely to trust their providers than white patients. And that's a real problem, because they're less likely to go to providers in the first place. They're less likely to follow through on treatment recommendations or recommendations to see a specialist if they need to. Again, these are all contributing to the disparities that we saw in those graphs. And then the final answer is just inherent racial discrimination. There are studies out there controlling for every single variable that we can: socioeconomic status, clinical condition, age, and yet black women still have a higher risk of dying from breast cancer than white women. And it's a shame that we are still observing that in the country, but it is a very real problem we're facing today, and it is a very real problem in the southern United States. So to kind of sum it all up, we know that the UK has a problem in screening and being very aggressive about screening at an earlier age and catching it early. But the United States has a lot of work to do in order to solve the system. So we have to improve financial access to the system, whether we make it free at the point of service or make some of these things more accessible, or really have true universal health coverage. We also need to overcome historical racial discrimination. I think that needs to be reflected in diversity of healthcare professionals, cultural competence, those kinds of things. And then if we're serious about controlling healthcare costs, we should also perhaps consider a cost-effectiveness organization in moving forward. But thank you very much for your time, and I appreciate it.
All right, so I am the last person on this panel. Hopefully you're not too restless or anything, but I must admit that I am a Southerner, and that with age, my voice is, or at least my cadence, is probably slowed down. So I'm going to try to use these 10 minutes as quickly as possible, but I will gladly admit that I might ignore the signs. So a lot of my work has been done regarding incarceration and also the health consequences of incarceration. And during some of that time, I've come across some puzzles. And one of those puzzles comes up in this first slide, where was trying to understand why I couldn't actually do the kind of study that I wanted to do. In this particular study, I was looking to look at age-specific mortality rates by race and ethnicity, and then also look at incarceration-specific rates by race and mortality and ethnicity. And thinking about, okay, well, we have physical death, and we also have a death that some might argue occurs when one is incarcerated. And those kinds of ideas might modify the behaviors of people earlier on in life. I wanted to do the study, I really wanted to do it, and I couldn't do it because something was missing. There was basically a framework or theoretical sort of thing where I wanted to ground these sort of questions in that I just couldn't do without. And so that's what I'll be talking to you today about. Now, one of the studies that I've done that has received some interesting attention looks at what happens when we compare the age-specific mortality rates of white men and black men, all right? Now, I'm not sure which one of these is the light. Whoop, that's not it. And that's why you always bring your own lighter. Always bring your own lighter. All right, so in this first graph, what we're looking at is the age-specific mortality rates of black men. Now, at every single age, the age-specific death rates are actually higher outside of prison than inside of prison, okay? Here, we're looking at the age-specific death rates of white and black men outside of prison. At every single age, the age-specific mortality rates, well, death rates to be quite frank, are higher for black men than white men. Now, when we go down to these two graphs, all of a sudden we see very little difference. In fact, there is no significant difference between white men in prison and white men not in prison in terms of their age-specific death rates. What's going on, right? But finally, we get to this really interesting conundrum here, where if we look at white and black male prisoners, there is no significant difference in white men and black men. So the age-specific, the mean length of stay during this particular time in question was 2.262 years. Now, you know you're a nerd if you can't stop at 2.3 and you have to go 3 digits out. 2.262. I don't know how to fix it. Nevertheless, this is a very short period of time. All of a sudden, this gap goes to this. And so essentially, we see that black men in prison actually are exhibiting the same age-specific death rates as white men not in prison. So, some people have said that, oh, so you're saying prison is good for black men? Well, let's send them all to prison. Well, we've already done that. So, that's not it. I think what it implicates, rather, is how horrible of a society, of a world, of a space we actually have outside of prison, such that prison actually looks good. Because it's not good. I promise you that. I've been. Not because I've been incarcerated, but rather because it's just part of one of the things I like to do. All right. The other study that sort of informs some of the continuing work that I do is looking at post-prison mortality, okay? So people wanted to argue and say, okay, so you know what, you said that prison is good for people, prison's good for people. I'm like, I didn't say that. In fact, for every year that someone spends incarcerated, they lose 2 years off of their life expectancy. Now, this is a paper that scared the crap out of me, okay? And it still scares me a bit, to the degree that I actually thought to myself, there's no way I can actually publish this. This has to be wrong. But I did it in several multitudes of ways, and then some really great journals said, hey, let's publish it, but let's not call it the hidden death penalty. Instead, think of something a little bit more neutral. So, I tried, but I still call it the hidden death penalty. All right, so every year in prison, 2 years off life expectancy. Now, there were some other studies that sort of made me a little sort of just like, a little bit more curious about what's going on. So one of those studies involved looking at the difference in the proportion of people who were incarcerated, looking at it by ethnicity. And not just saying, okay, well, we have Latinos, and then we have non-Latino whites, we have non-Latino blacks. No, no, no. Instead, trying to actually think about what do people see, okay? And so I actually looked at non-Latino whites and Latino whites, non-Latino blacks and Latino blacks. And one of the really interesting things that came out of this, for me at least, was that even though, for the most part, the narrative is African-American man, African-American man, African-American man. That's usually what we hear in terms of who is suffering the most from this mass incarceration. Latino blacks, they suffer more. And I'm only talking about citizens here, all right? So that was a little crazy for me, but I said, okay, well, what's going on? And I wanted to just look at it further. The other thing that came out of one of my studies was just the idea that, well, with sentencing policy, we've tried to make things equal, and that's why the U.S. Sentencing Commission has ordered certain judges to have less discretion, etc. But depending on where we actually measure that mean length of stay, or the actual maximum sentence served, or how long people actually served in prison, it varies. And so some of these things get masked because of how we actually measure them. And with that, I said, okay, well, maybe the reason why I can't actually do the study I want to do is because there's not an actual framework to consider these things. But perhaps if I thought about life and death in terms of the ways some scholars have already thought about it, social life, social death, physical life, physical death, civil life, civil death, then maybe I can get somewhere with this. So, there are these things that we call social institutions. And I'm sure you know about them, but maybe they haven't been framed this way. But basically, these social institutions are things that we see in all societies, and that typically have a positive, or at least can have a positive effect. Sometimes they have a negative effect. But when we think about education, certainly it can have a positive influence on one's life, and certainly one's longevity. You think about religion, certainly that's been found to help in terms of health, and law, economy, and so forth. But I can't really talk about that because I know I'm really short on time probably already before I even get to the meat of things. But the argument that I'm seeking to make is that the carceral world is in itself an institution. And it slices through all those other social institutions and modifies the way in which we can actually understand. Man, I'm down to 2 minutes. All right, see? I knew exactly what was going to happen. So the question that I started to ask myself, well, okay, well, what is the relationship between the carceral world and these primary social institutions? And so I started with thinking about what is civil death? Well, civil death, we have civic engagement, people can vote, people can be on juries. We have ways in which our voices can be heard. Right now we have this presidential thing going on, and it's a little crazy, but people's voices are being heard, okay? Civil death means that you are no longer engaged civically in society. We remove those privileges, we take them away, and if you look at this map, there are 11 states where if you have been marked by incarceration, then you permanently lose the right to vote. No voting, just bad. Social death. I define social death as the embeddedness in a network of people within a social system. Now, all social systems are not created equally. Some of them are actually helpful in terms of social capital, or actually, let's say that you're arrested, okay? And you call your friend whose father is a judge. Well, maybe you won't actually even experience, I don't know, anything. Maybe you'll just be driven back to Vanderbilt's campus. I've heard that happens sometimes. I don't know if it's true, okay? Got physical death. That is the absence of life, all right? Glimmer in my eye when I talk about it, but it's not because I'm morbid. It's because it's the absolute absence of life. And that in and of itself to me is pretty powerful, because everything else in terms of population studies is a choice. So I'm going to move to this last piece. Okay. These are the three important pieces for me, at least, that after thinking about it for a while, really matter. There's the interaction proposition, okay, where there's actually an effect that is exacerbated depending on how alive or how dead you are socially and civically. There's also the rebirth proposition. So with some types of death, certainly not the physical one, but the social one and also the civic one, you can be reborn, but the more time that you actually go in between the carceral world and the non-carceral world, the more likely you are to actually just, well, die physically as well, all right? And the last one is the stillborn proposition. In this proposition, I say that there are certain groups of people who are born stillborn, civically and socially. Because of the idea of concentrated disadvantage that is passed down throughout generations, there are some people who have never experienced any type of mobility to the degree that they are dead. So, this is a table that I was going to show you, and I was going to try and do it really quickly, but I'm just going to show just like the final table. I just want to make one little point, or three. All right. So if you have this initial life state of free, okay, if you look at it among black men, and this is the cumulative amount of time people can spend in a destination life state. So 30 years that they begin their adulthood free. If they begin their adulthood in prison, then, well, that's 0, okay? And mark also 0, because once you actually go through prison, you can never be free again. What I really want to sort of press upon, though, besides that racial difference between free men who are white and black, is more so the marked life state. So if you're marked by the harshness of incarceration, etc., which maybe it might not be so harsh, but it actually is, okay? Then you're going to suffer other things. We are going to suffer as a society because you're going to be less likely to be able to get a job. And if you do get a job, it's probably going to be one of low wages because of the actual structure within the society where there's legislation that prevents you from doing things. Just 1 minute, I swear, 1 minute, I promise. All right. So that means that for, on average, 10.4 years, that means that you're contributing much less to our economy. And so we are not benefiting, your family's not benefiting, your community's not benefiting. But if you begin your adulthood in this life state of imprisoned or marked, which, given what we've seen with the school to prison pipeline, is it's a lot more common than we'd like, then essentially we have killed you. We have killed you in terms of actually being able to give to society in meaningful ways, and we lose out. Not just the people who we have criminalized, who we have incarcerated, but we as a society lose. All right.
Well, we have about 10-15 minutes for questions, but before we do that, let's just give a huge hand to our panelists. Really not an easy job at all to frame a conference, but I think that really they've laid out a series of themes for us that I think are very important for the conversations we're going to be having. Also, just before people leave, a quick reminder, I know students have to go, that if you're really depressed about some of the things you've heard, we're having a reception tonight after the Melissa Harris Perry talk, and lots more events tomorrow, but just want to thank everybody. So why don't we open the floor and see if people have any questions. Yep. Somebody over, please.
In terms of, this is for Sarah Rudasill, did you see major differences in how many were treated post-autopsy, maybe had cancer and then died? Because sometimes a lot of people slip under the radar due to that kind of measure.
Testing. There we go. So thank you for your question. The question was, do they look at these things post-autopsy because a lot of people slip under the radar? And the thing is, they don't actually classify it. So I can't get the government data broken down by that and from the UK. However, I will say we've looked at other conditions as well. I only had time to present on breast cancer, but these same scenarios you see play out with prostate cancer, with cardiovascular disease, with infant mortality, and it's too consistent to be a coincidence. So I think that provides evidence that this is actually a problem.
Please.
Yes, Monty Platt from Georgia Tech. Thanks to all of you. So my question actually is for Dr. Wilkins, although I would love to hear Dr. Patterson continue talking. But Dr. Wilkins, so it's interesting that you described that mouse experiment, which is quite interesting. So can you speak on that in the case of reparations and how that can play into a reparations discussion?
It's on already.
It's on already? Yes, it is? Okay. I'm not really sure how it would play out in a reparations discussion. I think if we look at what we do know from research, when you have had this kind of exposure and then you put people into a different kind of setting, so what the normal setting is, often they can recover to some degree what was lost, but you never catch up to what was what would be the norm experience. So, for example, if you feed mice a fatty diet versus a normal diet, and then you, after a certain point of time, move them back to the normal diet, so they can get back to a healthier weight, but they're still at higher risk of some of the other bad outcomes. So, what does that mean that we shouldn't think about how to improve the system? I don't know that reparations is the ideal, but if we think about infusing resources, looking at doing research infrastructure, how do we better understand or repair the impacts of slavery and poverty, I think probably takes many years, but certainly doesn't mean that we shouldn't make those investments and start to try. And perhaps we should be focusing on stopping what's going wrong so that we're actually evening the playing field a little bit more. I don't know if that's where you're going. Yeah.
I have a question for the entire panel. So basically, we heard different versions. We saw in the beginning the mortality rate and looked at how the South, I mean, we basically had different layers of unpacking with each talk about how the South, in a particular way, and I guess part of my question is, would you agree with this, has a particular health crisis, which is there are trends in the morbidity and mortality in the U.S. South that are going in different directions, and particularly for certain demographic groups. Also, as we know, recently from a Princeton study, for white men, even so some surprising trends as well. So I guess partially it's, do you think there's a health crisis of the South? And I guess for each person, even though everybody kind of talked about this already a little bit in their talk, what do you think needs to happen, moving forward to reverse that? So, John, we can just go on down. I know that was a big part of your talk, but.
Yeah. So I didn't get a chance to discuss the work that we're doing here, which just kicked off last year, but that's going to touch a bit on this. Is this?
Yes, you're good.
You can hear me anyway, but so yeah, I think the statistics bear out, the issues that the South faces almost uniquely relative to the rest of the country, and the issues that Dr. Wilkins touched on, the fact that a lot of the biomedical research is drawing from local populations, but is scattered throughout the rest of the country, really reflects where the priorities end up in terms of where treatments are developed and which populations they're developed for, optimized on, et cetera. So what we're doing now here at Vanderbilt with my colleague up at Harvard, Michael McWilliams, we're starting to look at these statistics throughout the South. We have a cohort of about 90,000 Southerners recruited at community health centers that we're building upon. That was not our cohort, it was already recruited. And we're starting to look at their outcomes, whether or not they live in a state that's, for example, expanded Medicaid. And what's really interesting is that if you look across the Medicaid expansion, non-expansion divide, the states that expanded and that haven't expanded yet really are very similar on these statistics. And so we're going to get really good scientific evidence coming out of what's an unfortunate natural experiment that's happening with some states deciding not to provide health insurance, where we're going to look at, for example, changes in mortality, changes in cancer diagnoses, at which stage people are diagnosed at when they have access to certain types of health insurance. So over the next year or two, we'll really start to get some more concrete evidence on where the issues are and what levers we can pull to affect health outcomes in a good way. So,
Well, you can't look at those data for health conditions in the South and not believe that there's an incredible amount of work to do here, and that it is a challenge not just to lives and well-being individually and that of families, but also to the economic future and well-being of the place. And if we had a longer time to talk, we'd talk about the fact that business and business leadership is beginning to understand that and coming together in a kind of coalition that didn't exist in the past, together with health scientists, health funders, philanthropists, and people who care about this issue to try to build that basic consensus. I think in terms of the long term, or near to long term, the interesting challenge will be whether or not, as John suggests, we will move toward a greater level of not just insurance, but coverage, protection, and programs, or whether or not the rest of the country will actually join the South in considering that there should be less. It is not something about which there is absolute agreement in America, and you can watch the presidential campaign play out right at this moment and make your own decision about both where America is and where the politics of that will go. But know this, there is no inevitability of this going one way or another. Tennessee, which was #1 in America for health insurance in the late 1990s, is no longer. We disenrolled. It can go up and it can go down, and the only way in which you can have agreement about this is to build the kind of consensus I think that this program and this discussion is very supportive and helpful to, but which will require all of us to be involved.
So I think that one potential, or I shouldn't frame it as what the promise is. I'll talk more about what I'm excited about. So the President's Precision Medicine Initiative and a new sort of type of research and potential for healthcare that is focused on how do we look at individuals and how can we tailor treatment, not just on group averages, but how can we think about what you as an individual, what your genetics, your environment, your behavior, your social circumstances, what do all of those things mean to your risk for disease? How do we prevent disease? How do we treat conditions once you have them? Is something that I hope will begin to help us get past some of the challenges of using data that to treat people that really doesn't reflect those individuals and their biology and those circumstances. So I'm hopeful that as we begin to build more on big data and opportunities to really merge environmental data with clinical health records, that we can start to see how to tailor treatment and prevention strategies for individuals. And I'm hoping that that will remove some of the demographic and geographic lines that are defining us in our health.
I actually don't remember the question. Crisis?
No.
Is there a crisis? Or?
It's do you believe there's a crisis of the South, and what do you think needs to be done about it in the short and medium term to address it?
Okay. So do I believe there's a crisis in the South? Sure. Health-wise, incarceration-wise, there's a crisis. What do I think can be done in the short term? Well, one of the most exciting things to me that's going on in Nashville right now is this sort of, let's see, what would we call that? People getting together who can actually affect change. So the juvenile justice judge is partnering with the chief of police, who is partnering with social services, and they are partnering with education. And each of them are coming together to try and think of ways such that if a kid does appear before the judge, that they make up a plan to actually try and figure out what's missing in this person's life such that we can help them and such that they never appear again before this judge. And so that to me is very exciting about Nashville and something that is exciting in general because in most places, most spaces with social problems, we don't actually cross lines, whether it be disciplinary or even just functioning-wise. But to me, that's very promising. The other crisis that I guess I would say I see is more of a sort of a legal terminology. Well, okay, it is a legal terminology. Fruit of the poisonous tree. So typically when one is arguing a law case or something, evidence can be thrown out because you made an illegal arrest, and so anything after that doesn't matter, okay? So similarly, I think historically, there have been things that all of a sudden now that we don't see as being so much of a big deal. Now, not particularly in this state, but maybe in some other states. For example, the legalization of marijuana use, being recreational. Whereas in the past, it's a federal crime. It still is a federal crime, I'm sorry. It's still a federal crime. I am not advocating the use of marijuana use, okay? But what I am advocating is if all of a sudden we decide to decriminalize something, then we're actually admitting to something. We're admitting that we either overreacted or, well, we were just wrong. If we were in fact wrong, then we can't actually just dismiss the evidence because we've already taken years away from somebody's social life, somebody's physical life, somebody's civic life. So then comes the question, what do we actually do? Is it something that we can do from within this particular social structure that we have, or do we actually need to rethink the embeddedness of the legislation and the historical, traumas that have come about as a result of just people being people? I don't think there's any need to actually push blame on people, but I do think there is a need to acknowledge the harm that has been done and the fruit of the poisonous trees that we have planted.
Well, as it pertains to gun violence, I do think that there is a problem in the South. I mean, there's a problem in the entire country, but there certainly is a problem in the South. What's been validating for me personally is having a lot of my own anecdotal observations proven true, and a lot of research studies that come out that sort of prove what I had believed all along. In terms of how is now there are people who are beginning to see gun violence as more of a public health issue, and so what we're seeing is a lot more medical organizations getting involved, and validators, other groups besides just political and politicians getting involved. So I think when you can involve those validators, physicians, academics, researchers, law enforcement, district attorneys, organizations like that are not necessarily considered always to be political, and you can bring them into the conversation, you can kind of rise above the noise a little bit. What's also helpful, I think, is looking at other states where they don't have as much of a problem with gun violence, and trying to see what they're doing in those states that's working, and then trying to implement some of those same policies in the states like Tennessee where there's a problem.
All right, and then to just briefly summarize my colleagues, yes, there is a crisis in the U.S. South. I think we're all pretty confident that there are ways forward and policies that we can adapt. So whether it's increasing financial access to care, increasing diversity of health professionals, mobilizing groups on the ground to rectify injustices, there are ways forward, and we're going to find them. So.
Great. So before we clap, let me just remind everybody that Professor Harris-Perry will speak at 5 o'clock at the Divinity School, and there'll be a reception following. We have about a 45-minute break now. There's a bon pan across the street. But let me also say just how awesome this is. We've had multiple voices from policy, political, academic, activist, student, really a very diverse cross-section of laying out not just the issues we're facing, but I think encouraging steps forward that hopefully really sets a high bar for the rest of the conference. So thank you all so much.